Hello everybody, today we'll study about shoulder dislocation. Definition: dislocation is defined as complete displacement of articular surfaces of a joint and thus all contact between them is lost. There is another thing known as subluxation, when the articular surfaces are only partly displaced and retain some contact between them, then that is known as subluxation. We can see over here, this is the normal knee joint. This is subluxated knee joint, and this one is dislocated knee joint. Introduction. Most shoulder joints is the most unstable large joint. The mobility is at the expense of stability, inability to maintain humeral head in glenoid fossa. Reasons of instability are shallow glenoid, extraordinary range of motion, and vulnerability of upper limb to injury. It occurs more commonly in adults and is rare in children because epiphyseal plate in children is weak and tend to fracture before dislocating. Anterior dislocation is much more common than posterior dislocation. We'll see that why later. Mechanism: a fall on an outstretched hand with the shoulder abducted and externally rotated is a common mechanism of injury. Also, it may result from a direct force pushing the humerus head out of the glenoid cavity. Here we can see that this granny, she fell anteriorly on her ventral side, and therefore the shoulder has come anteriorly. In this picture, we can see that force from behind the shoulder can dislocate the shoulder anteriorly. In this picture, the granny's hand is abducted and externally rotated. Posterior dislocation may result from direct blow on the front of the shoulder, driving the head backwards. More often, posterior dislocation may also occur due to electric shock or epileptic convulsion. This man, this is in the third photo, this man has fallen anteriorly with his outstretched hand. This leads to head of humerus going posterior to the glenoid cavity. Pathoanatomy: anterior dislocation. Head of the humerus comes out of the glenoid cavity and lies anteriorly. There are 4 types of anterior dislocation. First one is subcoracoid. This one is subcoracoid. The head lies below the coracoid process. It is the most common type of dislocation. The second one is subglenoid. Humeral head sits inferior and slightly anterior to glenoid and also travels medially. The third one is intrathoracic or preglenoid. The head lies in front of glenoid, and the fourth one is subclavicular. The head lies below the clavicle. This is anterior dislocation. Posterior dislocation. In this, the injury of the head of humerus comes to lie posteriorly behind the glenoid. Here we can see that the head of humerus is behind the glenoid cavity. In inferior dislocation is also known as luxatio erecta because arm appears to be permanently held upwards in fixed abduction. We can see that in this picture. This is a rare type where the hand comes to lie in the subglenoid position. In the picture, it's not clear, but the head of humerus has come slightly inferior to the head of the humerus. Head of humerus has come slightly inferior to the glenoid cavity. Pathological changes in anterior dislocation. First one is Bankart lesion. In Bankart's lesion, dislocation causes stripping of glenoid labrum. This is the glenoid labrum, along with the periosteum from the anterior inferior surface of the glenoid and scapular neck. So this is subglenoid space, and this is the scapular neck is behind this. And if the tear is accompanied by a fracture of the bone of the glenoid rib, then that one is known as Bodhi Bankart lesion. So this one, the chipping of Glenoid labrum is known as Bankart's lesion, and if some amount of bone of glenoid rim also comes out, then that is known as bony Bankart's lesion. The second one is Hill-Sachs lesion. It is a posterolateral humeral head uh, posterolateral head depression fracture resulting from the impact with the anterior glenoid rim, therefore indicative of anterior glenohumeral dislocation. Okay, so rounding off of anterior glenoid rim occurs in chronic cases as the head dislocates repeatedly over it. There may be associated injuries like fracture of greater tuberosity, rotator cuff tear, chondral damage, etc. Diagnosis. Presenting complaints: shoulder abducted. So we'll see this here. Shoulder abducted. This is abduction of shoulder. Elbow flexed. Elbow is flexed over here and supported with opposite hand. Here we can see that. History of fall on an outstretched hand followed by pain and inability to move the shoulder. On examination, normal round contour of shoulder joint is lost. We can see that over here. And it becomes flattened. Fullness below the clavicle due to displaced head. That's what the patient feels, and this can be felt by rotating the arm. When the arm is rotated, the patient feels fullness below the clavicle in the axilla. One more thing is there is a humeral head is prominent over here. Signs: Duga's test. Duga's test. In Duga's test, the patient is asked to touch the opposite shoulder, and then elbow joint of the patient is pushed downwards so that it touches the chest of the patient. Doing this, the patient feels pain in the shoulder. In this picture, we can see that the clinician is trying to push down the elbow joint when the opposite shoulder is touched, and the patient is feeling pain in doing that. So the Duga's test is positive, and therefore anterior dislocation of shoulder has occurred. Second one is Hamilton rule test. Hamilton ruler test. Because of the flattening of the shoulder, it is possible to place a ruler on the lateral side of arm. This touches the acromion and lateral condyle of humerus simultaneously. In this picture, we can see that it is touching in this picture. Yeah, it is touching the acromion process and the side and the lateral side of the arm at the same time. Lateral condyle of humerus at the same time. This one and this one. In this picture, acromion process is not touched because of the lateral condyle of humerus. X-ray. This one, in this one, we can see the head is anteriorly and slightly inferior to the glenoid cavity. Head of humerus is slightly anterior inferior to glenoid cavity, and this is anterior dislocation. In this one, we can see that the position of the head of humerus is posterior to the glenoid cavity, and therefore this is posterior. This is also anterior dislocation. In this picture, in this X-ray, we can see that the head of humerus is slightly anterior and inferior to the glenoid cavity. So this is anterior dislocation. In the second picture, we can see that the head of the this is the posterior anterior view, and in this we can see the head is anterior to the glenoid cavity. This picture labels the diagram, and we can see glenoid cavity over here, humeral head over here, clavicle over here, and humerus over here. Posterior dislocation, this is the glenoid cavity, and the head of humerus is slightly posterior to the glenoid cavity. So this is posterior dislocation. Inferior dislocation, in this picture, the head of humerus is slightly inferior to the glenoid cavity, and this is known as inferior dislocation. Techniques of reduction of shoulder dislocation. First one is Kocher's maneuver. This is most commonly used method. The steps are as followed. First one is traction. See this traction. With the elbow flexed, to a right angle, steady traction is applied along the long axis of humerus. Traction is pulling. The second one is external rotation. The arm is rotated externally and traction is applied at the same time. The third one, adduction. The externally rotated arm is adducted by carrying the elbow across the body towards the midline. Adduction of shoulder. And the fourth one is the internal rotation. The arm is rotated internally so that hand falls across the opposite shoulder. This is known as Kocher's maneuver. The second one is Hippocrates maneuver. In this method, the surgeon applies a firm and steady pull on the semi-abducted arm. He keeps his foot in the axilla against the chest wall. The head of the humerus is levered back into position using foot as fulcrum. We can see this over here. This picture is of Hippocrates maneuver. Complications. Early complications, injury to the axillary nerve, and late complications. Shoulder is the commonest joint. In early complication, injury to the axillary nerve, which results in paralysis of deltoid muscle with a small area of anesthesia over the lateral aspect of the shoulder. The diagnosis is confirmed by asking the patient to try to abduct the shoulder. Though shoulder abduction may not be possible because of pain, one can feel the absence of contraction of deltoid. In late complication, the shoulder is the most common joint to undergo recurrent dislocation. This results from the following causes. First one is anatomically unstable joint. Second one is inadequate healing after the first dislocation. And the third one is epileptic patient. Other complications are avascular necrosis of head of humerus and atrophic calcification or myositis ossificans. Posterior dislocation. 5 to 10% of shoulder dislocations are posterior dislocation. Shoulder is in adduction, flexion, and internal rotation. So the opposite movements are not possible. So abduction, extension, and external rotation are not possible. Shoulder occurs due to electric shock, seizure episode, or trauma from anterior side on shoulder, present with flattened anterior shoulder and prominent coracoid process. Inferior dislocation or luxatio erecta, hyperabduction injury. Hyperabduction injury because the arm is hyperabducted on the head. High rate of vascular, nervous, ligament, tendon injuries. Patient presents with affected arm hyperabducted and the elbow flexed and the forearm resting on top or behind the head. In this picture, we can see that. Thank you.